Grand Rounds. We are very happy to have Malika Rawal, who recently, 6 months ago, joined us as faculty, actually about 4 months ago, since she started in August. She did a residency at UPMC in Pittsburgh and started fellowship here in 2019 and completed in 2021. She has been with us for the last 4 months, has been growing her clinical and academic resume quite well. And she has an interest in general endocrinology and some special interest in transgender medicine, diabetes and obesity. So we are pleased to have her talk to us about Pheochromocytoma and Paragangliomas.
All right, thank you, Dr. Mokshagundam, for that introduction. And anyone that missed it earlier, today is Dr. Mokshagundam's birthday. So join me in wishing him a very happy one and many more to go. And I apologize in advance. I'm getting over a little bit of a cold, so I hope to get through this without losing my voice. But here we go. So my topic today is Pheochromocytoma and Paraganglioma. And I have no conflicts of interest to disclose. Hopefully by the end of today's talk, I will have provided you with information so that you're able to discuss the epidemiology of pheo and paraganglioma, so that you can discuss the presentation of catecholamine excess, to be able to diagnose catecholamine excess based on lab and radiographic testing, to discuss the perioperative management of confirmed lesions, and finally to highlight some syndromic forms of pheo and paraganglioma and common genetic mutations. So a lot of today's presentation will be based on the Endo Society 2014 guidelines discussing the diagnosis and treatment of pheochromocytoma and paraganglioma. We haven't had any updates since then, but they're a pretty comprehensive list of recommendations. So we'll be referring back to these from time to time throughout today's lecture. Some abbreviations to keep in mind. PCC is a common abbreviation for pheochromocytoma. PGL refers to a paraganglioma, so that could be either a parasympathetic or a sympathetic paraganglioma. And PPGL is a broader abbreviation that includes pheo and sympathetic paragangliomas. So getting down into epidemiology. PPGLs, these are very rare neuroendocrine tumors. They're kind of exciting for us as endocrinologists and to internists as well, but they are quite rare. And they usually arise from chromaffin cells, either in the adrenal medulla, in the case of pheochromocytoma, or from extraadrenal chromaffin cells, in the case of sympathetic paragangliomas. They only occur about every 2 to 8 cases per 1 million. So like I said, quite rare, with an overall prevalence of 1 in 2,500 to 1 in 6,500. Amongst all hypertensive patients, pheos are only responsible for less than 0.5% of adult cases of hypertension. So this kind of puts into perspective how rare they are. And they can occur up to 2 to 5% in pediatric patients with hypertension. Up to half of these tumors are diagnosed based on incidental findings, CT scans or MRIs done for other reasons and for other pathologies in the abdomen. And about 4 to 8% of all adrenal incidentalomas are eventually diagnosed as pheochromocytoma based on biochemical testing. Usually these tumors present symptomatically during the 3rd to 5th decade of life, although up to 1/5 of them can present in pediatric patients. As far as location, depending on whether we're talking about a parasympathetic or sympathetic tumor, there are common locations to find them. Parasympathetic paragangliomas are usually found in the carotid body and then in other ganglia in the head and neck, namely the nodose ganglion along the vagus nerve and along the jugulotympanic ganglion. As far as pheos and sympathetic paragangliomas, they're most commonly found in the adrenal medulla, along the aorticopulmonary ganglia, or around the organs of Zuckerkandl. I probably butchered that name, but just in approximation to the bladder. At some point in our education, we probably all have heard of the 10% rule, referring to Pheochromocytoma and Paraganglioma. And this was first coined in 51 by Dr. Graham. And he looked at about 200 cases and found that of these cases of Pheo and Paraganglioma, about 10% occurred outside of the adrenal medulla, 10% were bilateral, 10% in kids, 10% were genetic, and 10% were malignant. However, we've discovered that this is not quite true anymore. We've discovered a lot more germline mutations that are responsible for pheochromocytoma and paraganglioma. And up to 40% of all of these tumors are based on germline mutations, so they are heritable. About a third of the remaining cases have an identifiable somatic mutation as well. As far as malignancy and metastatic potential, as many as 1/5 to 3/4 of all hereditary cases can have metastatic or malignant potential, which is important to note whenever we diagnose these tumors. And up to a third of paragangliomas have the potential to be malignant or metastatic. And as we discussed earlier, 20% can occur in pediatric patients. So how does catecholamine excess present? The classic thing that we learn is the triad. So we look for patients that are describing headaches, increased metabolism that presents as tachycardia or palpitations, sometimes as presyncopal symptoms, and then hyperhidrosis. And this could be anything from hot flashes to patients that just describe themselves as always sweaty and always clinically have a little bit of perspiration. To be more inclusive, sometimes catecholamine excess can also present with hypertension and resistant hypertension and also hyperglycemia. So this is referred to as the 5 H's of catecholamine excess. Keep in mind that these symptoms are pretty generalized and vague, and a lot of different diagnoses can lead to these cluster of symptoms. So how do we metabolize catecholamines in the body? Understanding this is going to be important to figure out why we do the test that we do. So all catecholamines come from a common tyrosine backbone and are converted first to L-DOPA, then to dopamine and noradrenaline, also known as norepinephrine, and then finally to adrenaline, also known as epinephrine. In the CNS and sympathetic nervous system, we have the enzymatic machinery to convert all the way to noradrenaline. However, in the adrenal medulla, we can complete the pathway and go all the way to epinephrine or adrenaline. And this is going to be important when we look at our biochemical testing. If we see strictly epinephrine or metanephrine excess, that might lead us to localize the adrenal medulla as the source of the tumor. And our catecholamines are further metabolized to methoxytyramine, which is not a very commercially available assay, normetanephrine and metanephrine, and also to VMA in the urine. We typically tend to use the metabolites for our testing because they're more stable, they're secreted in a more constant fashion, and the assays are more sensitive for picking up changes in the levels. The biochemical testing we do, the most important thing that I hope that anyone takes away from this lecture is the degree of elevation is really what's key. And in a true PCC or PGL, you're going to see at least a 2-fold elevation, if not 3, 4, 5-fold in the normal levels or the normal reference range. There are many factors that can cause false positives in this testing that may get us in the range of 1.5 to 2 times the upper limit of normal, very rarely 3 times the upper limit of normal. And then the other important thing that we can see on this slide in blue is that sensitivity of these is quite high. So true negatives really are sensitive. And so if we have a suspicion for Pheo or PCC or PGL, and we do our metanephrines and normetanephrines, and they are normal, we can feel very comfortable that this is not actually catecholamine excess. So keeping this table in mind, before testing, we should really consider our pretest probability and whether there are other factors that might alter the levels of catecholamines. The common tests that we do are plasma-free fractionated metanephrines or norepinephrines. This test is actually probably the best. It has 100% sensitivity and almost 98% specificity. We can also do 24-hour urine metanephrines and norepinephrines, which are a little bit less sensitive and close to as specific. Urinary tests tend to be less expensive, but they're more laborious for the patient. Usually we say to do the urine when we have a higher suspicion for them coming back negative. Plasma-free catecholamines can also be done. 24-hour urine catecholamines are commercially available as a lab test. 24-hour urine VMA and chromogranin A. It's important to note that one cause of false elevation of our catecholamines is upright posture. So it's best to do your plasma levels of METs and catecholamines when a patient is supine. And again, for all of these, we expect our results to be at least more than twofold the upper limit of normal to really consider PCC or PGL. So here comes a long list of things that can falsely elevate our levels of catecholamines. So anything that it's going to increase our activity in our sympathetic nervous system. This means acute illness or pain, any severe emotional or mental distress, upright posture, use of pressors or L-DOPA, other sympathomimetic agents, nicotine, caffeine, and amphetamines, including cocaine and over-the-counter things such as Sudafed, and weight loss medications such as phentermine. Anything that's going to decrease degradation of norepinephrine and epinephrine, such as MAO inhibitors. These are much less commonly used, but important to keep in mind in case your patient is using one of these medications. Anything that's going to inhibit epinephrine and norepinephrine reuptake at the synapse. So this includes cocaine again, TCAs, SSRIs, and reuptake inhibitors such as venlafaxine or Effexor. And adrenergic receptor blockers don't actually alter the levels, but they may mask symptoms of catecholamine excess. So it's important to note in your history if your patient is using these agents. Lastly, assay interference. Acetaminophen or paracetamol may interfere with the LCMS assay if you're doing plasma levels of your catecholamines and METs or normets. So again, this is not a comprehensive list, but these are probably the most common situations. So in the guidelines, they, kind of summarize the most common agents that interfere with our testing, with, as we saw, acetaminophen being responsible for a lot of false elevations in plasma and urinary norepinephrines, and that's a pretty commonly used medication. So that's definitely something to ask about in your history. It's also important to keep in mind that there are medications that also can precipitate a pheochromocytoma in a patient. And they include some SSRIs as well, MAOs, steroids, certain peptides such as glucagon and ACTH, and neuromuscular blocking agents. So once we've done biochemical testing and we've confirmed that they have evidence of increased catecholamines, the next step would be to localize with imaging. Abdominal CT is a very commonly used imaging modality. It's available at most hospital centers. And on CT, you're going to see a lipid pore lesion, which is going to mean that the pheo lesions on an unenhanced imaging are going to have higher attenuation. They're usually well circumscribed, and they're usually hypervascular. So this leads to delayed contrast washout if you do use contrasted studies. In one study, they described a greater than 95% sensitivity for pheochromocytoma, even half a centimeter or greater than 5 to 10 millimeters rather. So they can pick up very small lesions. Once they're smaller, they may appear more homogeneous on imaging, but larger lesions tend to look like this one over here that are heterogeneous, and they have cystic and possibly even hemorrhagic components. In one study, it was described the 10 Hounsfield unit threshold. Basically, this means that most pheochromocytomas are going to have an unattenuated appearance of greater than 10 Hounsfield units. And this is based on a study of about 300 Pheos, and only one of them in that whole series had a attenuation less than 10 Hounsfield units. So anytime we see an adrenal incidentalloma and it has an unenhanced attenuation of 10 or less, we can feel pretty confident that it's not a pheochromocytoma. And they actually recommend in this case that you don't need to get metanephrines and norepinephrines unless you have clinical suspicion otherwise for pheo. So that just summarized what I said. So a very high sensitivity for ruling out pheochromocytoma if the enhancement is less than 10. So in the guidelines, they tell us that CT rather than an MRI should be the first choice imaging modality. MRI is also available, however, and you can use either T1 or T2 weighted imaging. So T2 is the one that's going to really help you clinch the diagnosis because you're going to have high signal intensity in pheo lesions. However, there is overlap between PCC and other adrenal lesions using both T1 and T2 MRI. And only 65% of pheos are correctly identified using either T1 or T2 weighted MRI. So the guideline says MRI should be reserved for patients that have metastatic pheo or paraganglioma for detection of any that might be at the skull base, or for people that have other reasons why they can't get a CT. There's also functional imaging studies that are available, such as MIBG or FDG PET scan, or even octreotide scan. But when to use them is a little bit more complex. In the guidelines, they tell us that an MIBG scan should really be reserved for patients that we have a high suspicion for metastatic disease because the primary tumor is very large, or because the primary tumor is outside of the adrenal medulla, or if they have recurrent disease. However, FDG PET scan is the preferred imaging modality if they already have known metastatic disease and we're doing surveillance. It's important to note that MIBG scan also has certain limitations, and there are certain medications we have to hold for up to 2 weeks before doing it, which are also common agents. So sympathomimetic drugs, cocaine, TCAs, calcium channel blockers, and alpha and beta receptor blockers, such as labetalol. Those agents are going to decrease the accumulation of MIBG and give us false results. So this is kind of like an algorithm telling us how to move along the imaging pathway. The recommendation would really be, unless they have a contraindication to getting contrast, to start with an adrenal protocol CT or an abdominal CT. If it's positive, we've clinched our diagnosis, and we can decide if we think they have a high likelihood of having metastatic disease, in which we need to do functional imaging, or not, in which we can proceed to surgery. How do we manage these patients once we've confirmed biochemically and radiographically that they have a pheo? So our first goal is to block the effects of catecholamines in the periphery. And this is first done with alpha blockade they recommend at least 2 weeks. Our target in alpha blockade is to bring the blood pressure when they're supine to less than 130/80 and to as low as 80/45 when standing without orthostasis. So once they endorse that they're starting to get dizziness and those kind of symptoms, we can back off of the alpha blockade slightly. Some regimens for this include doxazosine, which tends to be a more affordable option for patients. And the starting dose is usually recommended to be 2 milligrams, but you can dose anywhere between 1 to 5 milligrams twice a day until you reach the above target blood pressure. Or you can use phenoxybenzamine at a dose of 20 to 40 milligrams every 8 to 12 hours. That tends to be more expensive, usually requires prior authorization from insurance, and is less readily available at pharmacies. More recent articles have actually suggested that calcium channel blockers may actually be good adjuncts to alpha blockade, or even may replace alpha blockade preoperatively. But I think that the guidelines still recommend using one of these two agents first. So we could still consider nifedipine, amlodipine to help with hypertension control if that's an aspect of this patient's presentation once we have alpha blocked them. The next step is the beta block to counteract some of the reflex tachycardia that we may get. And our target is a heart rate of 60 to 70 while supine or 70, 80 while standing. They recommend you wait at least 3 days after starting alpha blockade to beta block, but sometimes even longer, I would say. In a lot of review articles I read, they wait until the heart rate actually goes over 100 before they even consider beta blockade. The next goal that we have before surgery is to minimize the risk for postoperative hypotension. This chronic state of catecholamine excess has basically led to a chronic natriuresis and volume depletion. So we need to bring the fluid back into their vasculature, and this is the one time that we're going to tell patients to, become best friends with your local McDonald's and liberalize your salt in your diet for several days before your surgery. So a very high salt diet, and then giving them saline perioperatively. A very important goal is to identify an experienced surgeon and anesthesiology team that are familiar with Pheo and the challenges perioperatively. We're very blessed to have amazing endocrine surgeons, and you want to look at how many surgeries that person has done, and that will tell you their level of experience. Lastly, you want to monitor for postoperative hypoglycemia. There has been some suggestion that those that have epinephrine secreting tumors are more likely to have this postoperative hypoglycemia. But any patient that is undergoing surgery for Pheo or paraganglioma should receive pretty regular glucose checks afterwards to make sure this is not happening. So now we get to for myself, the fun part, which is the genetics of Pheo. And so a lot has happened since Pheo first became recognized, and we've discovered a lot more genes that can potentially lead to Pheo or paraganglioma, as well as these syndromes. And why this is important is basically, depending on the type of gene, it's going to tell us their risk of metastatic spread. And that's going to change how we counsel the patient, how we image them, and the speed with which we try to manage this. So certain genes, such as the succinate dehydrogenase cluster of genes, tend to be more associated with metastatic spread. So once we've identified those, and also the von Hippel-Lindau genes, VHL, that gives us a higher suspicion for metastatic disease. Whereas other genes that are more commonly associated with Pheo and we've known about for a long time, such as the RET gene associated with multiple endocrine neoplasia 2, and neurofibromatosis 1 gene, NF1, are less likely to lead to metastatic Pheo or metastatic paraganglioma. This is a very busy table, which is from the guidelines, but it tells us the most commonly recognized genes that are associated with Pheo and the syndromes associated with them. So as I said earlier, known syndromes include von Hippel-Lindau, which we have retinal and CNS hemangiomas, pancreatic neuroendocrine tumors. We test for the gene VHL. Neurofibromatosis 1 is also associated with Pheos. RET is also as well. So RET is the syndrome that is either 2A, which is Sippel syndrome, where we have medullary thyroid cancer, parathyroid disease, and amyloidosis, or MEN2B, where we have medullary thyroid cancer and marfanoid habitus, such as pes excavatum, high arched palate. So looking for those features will lead us to have a higher suspicion to test for RET gene. And then a bunch of SDH, or succinate dehydrogenase gene mutations, can also lead to Pheo syndromes that include GIST and renal cell carcinoma. It's important to know these genes because they come with certain increased risks. For example, SDHA and B, which are both autosomal dominant, are associated with a 25 to 50% chance of extraadrenal tumors. So these are the most likely to occur outside of the adrenal gland. We know that von Hippel-Lindau gene, RET gene, and certain of the other SDH genes are more associated with multiple tumors. And then SDHB is the most commonly associated with metastatic disease. We should be particularly suspicious for metastatic disease or syndromic disease if our patient has a positive family history with a family member having a known mutation in one of those aforementioned genes, if they have any syndromic features. So if they have marfanoid habitus, they have renal cell carcinoma, if they have hemangioblastomas, they're looking for these syndromes, if they have multifocal or bilateral disease, or if they have metastatic disease. There is up to a 12% rate of germline mutations in patients that have 3 or 4 of these criteria. So even if patients have a negative family history, an absence of syndromic features, and an absence of bilateral disease, 12% of them may still have a germline mutation. So to me, this really emphasizes the importance of gene testing and counseling your patient once you've diagnosed a pheochromocytoma or paraganglioma. So this is a summary of things we talked about earlier, so I will move past that. So how do we screen these patients once we've identified a mutation? So these are some of the most common syndromes. Rett associated with men 2A and 2B. Every year we should measure calcitonin to screen for a medullary thyroid cancer. We should check annual metanephrines and serum calcium to monitor for the potential of primary hyperparathyroidism. Those with von Hippel-Lindau mutation, we should monitor their metanephrines and perform routine imaging of the brain, spinal cord, and abdomen to look for benign tumors, perform a yearly eye exam, and then if everything looks clear, then we can space out monitoring every 2 to 3 years. Those that have SDH mutations are the ones that are more likely to have malignant and bilateral disease and metastatic disease. So imaging is going to be important for these, and they recommend imaging every 1 to 3 years. So the guideline tells us that all patients with pheo or paraganglioma should be engaged in shared decision making for genetic testing, that we should use a clinical feature-driven diagnostic algorithm to establish if there are certain genes that we need to test for first, and that all patients with paraganglioma undergo testing for SDH mutations, and anyone with metastatic disease be tested for SDHB in particular, and that genetic testing for these tumors should be delivered within the framework of healthcare, which means what is available in our network, which are validated genetic testing, and that we need to discuss very frankly the implications for family members and the importance of testing family members once we've identified a gene mutation. So I think I finished ahead of time, but here's today's event code, and I am happy to answer any questions. No, there wasn't anything about tuberous sclerosis, so the question was if that was an associated mutation with pheo. Oh, okay. Okay, so Dr. Krishnasamy shared that one of her patients recently was diagnosed with a sporadic pheo and also had tuberous sclerosis, and her daughter similarly had both has the mutation for tuberous sclerosis. So wondering if there was any implication. And I haven't seen that, but again, some papers list like over several hundred mutations associated, and the Endo Society guidelines stick to these more common ones and the ones that have assays available for them. So that would be interesting to find out. Okay. All right. Chat. Oh, thank you so much, Dr. Levinson. Congratulated me. Gallium dotidate scanning. Okay. So I think that any functional type of imaging, the recommendations are to reserve that for when there's a high suspicion for metastatic disease, or say you do your CT and MRI, you're not able to localize a tumor, but you have biochemical evidence that there is catecholamine excess. then the next thing would be to do any kind of functional imaging. So certainly gallium dotatate scanning if that's available at your institution. Thank you, Doris. Any other questions? Okay. How long, Dr. Mokshagundam asked, how long do we monitor patients? So are you asking if they've had Pheo? I would say, yeah. If there's no mutation, I mean, 12% of them could still end up having bilateral disease or metastatic disease. So I would say, I have no evidence to this. I would say for a period of 5 years, I would do annually. Then after that, I would space it, but I would do a lot of education about the symptoms to look out for and recommend they have someone like their PCP check their vitals regularly, at least every 6 to 12 months. It is common. Yeah. Yeah. So the question is, if hypertension persists after pheochromocytoma is treated, how do you continue to monitor those patients? And I think that's a great idea. I think if they continue, as long as they're hypertensive, I would do it annually then, and do metanephrines annually. I would do urinary to try and lessen the burden on the healthcare system. Oh, the code, yes.
Well, so one of the things that's been normal.
Mm-hmm.
The overall number of people tested probably
Mm-hmm.
because everybody gets excited. And then and I think
Yeah, so Dr. Mokshagundam was, again, commenting on the positioning during doing plasma metanephrines and saying, that the issue is more if the result is elevated and the patient was not supine, that's when you run into problems. But of course, if the level is normal, regardless of posture, then, your sensitivity is high enough to rule out catecholamine excess. But, the point brought up there is if your elevation is 1.5 times the normal, and, the symptoms, if your pretest probability is high, the level is only 1.5, but they give a really good picture. They give a really good story where even when you look at them in the room, they're sweating, they're tachycardic, and they may have some interfering medications, but it's not feasible to stop them. Then the recommendation is to do a clonidine suppression test to kind of suss out those borderline ones, or to try to stop those interfering agents if possible. But a lot of times it's not, and it's not the best thing to stop someone's SSRI. Dr. Caldwell?
What size?
Oh, for a Pheo, what size Pheo? Myo. Oh. I would say we recommend a tumor more than 4 centimeters for adrenal incidentaloma to remove. So I think that could be similarly applied to myolipoma, but these tend to be just benign things that, unless they cause local compression, could stay there forever. Yeah.
Myelolipoma is asymptomatic.
That's where the
Yeah, I feel that if you can avoid a surgery for something that's not going to have malignant potential and unlikely to grow and cause compression, like as in the case of myelolipoma, then that's probably the best way to go. Yeah. So imaging wise,
they have.
So the question from Dr. Pansari is there a such thing as a silent Pheo where imaging wise they have a adrenal mass that looks angry like a Pheo, but biochemically they're normal? I think there could definitely be that entity where it hasn't presented, in which case we need to be very, if you were to see an adrenal lesion like that, you would be prompted to check it. They're normal. I think I would advise a patient to avoid that list of drugs that is known to precipitate a crisis. I would see them more often in my office, and I would probably screen for other things and genetic test them.
So, recommendation.
Mm.
I think he spoke about it in the.
Right.
Yeah.
Because the thing is, the crisis is that are possible.
I guess the thing is we have such a high sensitivity, at least if your plasma metanephrines and norepinephrines are normal, with such a high sensitivity, would you still take it out?
Yes.
Okay.
I think he had.
Yeah.
That there is
always
a
this insulin secretion.
Okay. So you would.
Check it.
radiology.
So they're discussing an entity where you have a radiographic high suspicion for a Pheo, but biochemically they don't have catecholamine excess. So the recommendation by Dr. Young is just to take it out. So don't wait for a crisis, but to start your perioperative management and proceed with surgery. Any other questions? Okay, well, thank you so much. And again, happy birthday, Dr. Moak.